Шановні колеги, дозвольте розпочати пленарне засідання, яке називається у нас «Сучасний менеджмент діагностично-лікувального процесу з використанням цифрової медицини». Перш за все, я хочу перше подякувати організаторам, тому що насправді це дуже серйозний форум, і побажати плідної праці. І найголовніше сказати, що всі кошти, які за час роботи форуму будуть зібрані, вони всі підуть на ЗСУ для підтримки людей, які тяжкою працею, ціною свого життя дозволяють нам сьогодні отак от гарно вдітими, в теплі займатися ділитися науковими досягненнями. Отже, перша доповідь буде «Сучасні аспекти телемедицини та її реалізація». Це наш дуже великий друг Роберт Рейдак, професор, доктор наук, габілітований, проректор Люблінського медичного університету з цифризації, промоції міжнародного розвитку. Він віднедавна доктор оноріс кауза нашого університету. За час війни допоміг Україні не лише фінансово, а це порядка 1 мільйона злотих допомоги, це коло 9 мільйонів гривень, обладнанням, ліками і всім решта, але й оперував безоплатно наших дітей, поранених на фронті. Я сподіваюся, що його доповідь вона буде в запису, вона зацікавить багатьох, оскільки це, по суті, сучасні аспекти, нові аспекти цифрової медицини, які відкривають нашу секцію.
Ladies and gentlemen, good morning. It's my great honor and pleasure to present you our experience in telemedicine for mass screening, and especially I'm going to present telemedicine and the new digital diagnostic tools in ophthalmology. I am honored to collaborate with Professor Marko Zarbin from Rutgers University and Professor Andrzej Zimenkowski from Lviv. We know that diabetes and diabetic retinopathy is a really blinding disease in a working age group of patients, and diabetic retinopathy is present in 30% of diabetes mellitus patients, and 30% of them are in danger of diabetic macular edema and proliferative diabetic retinopathy, which are main causes of blindness. Throughout the world, complications of diabetic retinopathy really bring a lot of costs for the society. That is why we now decided to perform early diagnosis and early diagnostics of both diabetic macular edema and diabetic retinopathy, and especially proliferative form, using non-mydriatic fundus camera, also with coherence optical tomography. And I would like to show you on these photographs how accurate is now this tool, especially in combination with artificial intelligence. We see color fundus photograph, and on the left side we can see first symptoms of diabetic retinopathy. So our system tells us follow up in 6 months. On the right hand side, the photograph is showing really severe case. So artificial intelligence is telling that urgent follow up for anti-VEGF injection is needed. So if the disease is more advanced and we see a lot of vessels on the optic nerve disc, then we have information about urgent follow-up for laser photocoagulation. And if we see already traction retinal detachment and membranes on the surface of the retina, we get information about vitrectomy. If we can compare histology with fluorescent in angiography and novel techniques, we can see that histological examination and fluorescent angiography are showing us the same result. I would like to remind you that for fluorescent angiography, we normally should inject dye, fluorescein intravenously and take photos, and we obtain such results like peripheral vascular non-perfusion areas. We see these areas marked by arrows, and in the same time, if we are using also fluorescent angiography, we see new vessels, we see leakage, and if we compare this invasive technique, I remind you that we should inject dye, fluorescein, and take photos with totally non-invasive imaging end-phase images of OCTA. We see exactly the same results, even more. Microaneurysms, peripheral vascular non-perfusion. If we check the photo on the right-hand side, we see enlargement of foveal vascular zone, and also we see really big non-perfusion areas. If we also compare transverse sections taken with non-invasive imaging, OCT-B, we can see diabetic macular edema, we can see fluid in the macula on the right-hand side. Just to compare with normal macula, on the left, you can see these differences. And of course, artificial intelligence can detect it easily and provide us with information about need of treatment. In US, our colleagues use iNook software, and in Poland we are working at the moment on our own software and our own artificial intelligence algorithms to be used soon in our system. So normally I would like to present you now the model we started to work with the model from New Jersey, from the group of Professor Marco Zarbin, who is since years our friend and collaborator, who brought a lot of ideas to Lublin, and we could start our own project since a couple of months ago. So you can see, if you use non-invasive camera, you can take fundus photographs. Also, you can see many other information. The OCT-B is showing you also macular edema. You can have a transverse section. You can have end-phase photographs, as I showed you before, and you can check macula. You can check cortical vitreous, also presence of traction on the macula region. You can combine fundus photographs and OCT scans. This system can be used not only for diabetic macular edema, but also to detect other diseases like cataract, like also glaucoma. You can scan angle and anterior chamber angle, anterior chamber depth. You can have many information about the eye globe. So it is very useful for ophthalmologists. This is how it works in US. Normally, you take photographs when the patient is standing in standing position, just not to waste time, to make it fast. And then, of course, artificial intelligence is checking all results. If there is any symptom of diabetic retinopathy, then we obtain information that we should have also OCTA and OCTB information. There is also a possibility to contact retina specialist. There is a special tele-robot and both technician, because of course I must stress that all examinations are done by technicians, and ophthalmologist is receiving only findings which are suspected to be already symptomatic for the disease. So you can see how fast is this examination. We can examine 120 subjects per day and almost 500 per week. This is how fast is this examination. Watch video, please. First, not the graphic camera. So take photograph. So in 3 minutes, 16 eyes. And now OCTA and OCTB. Of course, these patients are already, let's say, examined because they have symptoms of diabetic retinopathy found in fundus photograph. In 5 minutes, we can examine 15 eyes. So again, to summarize how the system works, first we take fundus photographs, then if necessary, if there are symptoms, we are using OCTA and OCTB, and we can also remotely contact and discuss with retina specialists. And in US, there is a vehicle and a team of technicians and nurses going to small villages, towns, and they transport the equipment. And normally the photographs and examinations are taken in the, let's say, building and the location which is normally where the equipment is transported. In Poland, we established a similar system with some differences, and the system works very well. First of all, our project is involving also family doctors, and we are implemented into e-system, e-health system, sending all results, also information between family doctor and ophthalmologist. We are supported by Fulbright Foundation, and I am the leader of this project. I am very proud to collaborate with Professor Andriy Zimenkowski from Lviv, and we are working at the moment on new projects, and we plan to gather grants supporting our collaboration between Lublin and Lviv. And this is the project from Lublin. This is iBus. You see the technician taking photos in the vehicle. These photos are sent all sent our partners. They are checked by specialists. Finally, the doctor is receiving information should be sent the camera is handled by technician. So the first part of the examination is done, let's say, in small villages, and the results are sent the Department of Ophthalmology in Lublin, and they are finally analyzed by our ophthalmologists. So again, I wish you really very fruitful meeting, very interesting discussions. Thank you very much for invitation, and again, I am very grateful for very interesting and fruitful collaboration with the group of Professor Andriy Zimenkowski. Thank you very much. Bye bye.
Включіть. Ага. Насправді професор Рейдер – це відомий офтальмолог, він президент Асоціації офтальмологів-хірургів Польщі, входить в топ-5, напевно, найкращих хірургів-офтальмологів Європи. Ми з ним співпрацюємо багато вже років, і цей проєкт, який ми зараз з ним робимо, це тільки початок. Ми готуємося до серйозного проєкту, який так само побудований на основі скринінгу і буде задіяти багато фахівців різних фахів. Це буде і електронна дерматологія, електронна анестезіологія, електронна хірургія, пластична хірургія і так далі. І офтальмологія в тому числі. Початок – це окобуз. Я сподіваюся, що в скорому часі окобуз буде і в Україні. А взагалі ми цей проєкт планували, і якась частина його так і проводиться, для дистанційного обстеження військових, поранених, і потім для прийняття рішень в, скажімо, центрі або в Львові, або в Любліні.